everyone, and welcome to our CT console once again. So we had got a query from some of our viewers to discuss the CT of colon and especially the ileocecal junction. So in this video we will see some cases of colon cancer towards the end of this video, and initially we will see how to trace the colon and rectum. In some cases we may be able to see the normal appendix and the ileocecal junction. So let us dive into our console. As you all know by now, this is an axial CT scan, and we will start from the pelvis and go above, and I will just show a technique of how I trace the colon on console, and then we will re-emphasize the need of viewing the scan on console with your radiologist when we discuss a few cases of colon cancer. So in this patient, first what you need to do is you need to identify the rectum, and as you go up you need to identify the sigmoid colon, right? So the anal canal opens into the rectum and from rectum into the sigmoid colon, right? So in this patient there is no rectal contrast, but you can still make out. So I will be marking the trajectory. If you follow this line, this is where the rectum is, right? As I go up, this is the beginning of the sigmoid. There are a few diverticula in that area. Now as we go ahead, you can see it is turning here. How you can identify this part of intestine is by the fecal appearance, right? The mixture of air along with other contents is what makes us identify the colon usually. Or if you have given the contrast, then the Hofstra can be seen. The colon is distended by negative contrast, and positive contrast makes it even more easier, right? So here you can see that I am tracing the colon. I will go down again, right? This is the anal canal region. As we go up, the rectum, the beginning of the sigmoid with a few diverticula. Then this is where it is turning. Usually this turn is always there, and then you have the sigmoid, right? This is the sigmoid. Keep tracing it and you will be able to follow the entire colon, right? So this is the sigmoid colon. You can see the characteristic shape of the sigmoid colon, right? Going here. Once you reach the upper end of the sigmoid colon and you reach the descending colon, right? Then it stays in this area only, right? So that is the beginning. This is now the descending colon as it goes up, right? As it goes up, you can see the beginning of kidneys, right? This is the left kidney and this is the colon, right? So just keep that point in mind. I'll remove rest of the marks, and this is the colon. Again, as we go up, you will come towards the spleen, and that is the splenic flexure, right? Therefore, this is the splenic flexure, right? So now you can see, right? I'll show again. This is the splenic flexure, and this is how the colon is turning from here to here. So as we trace it, just keep moving console front and back, and you can trace the entire transverse colon as well. This patient does not have any pathology in the colon. That is why I selected this scan just to trace the colon for you, right? So this is the entire transverse colon. I'll again say it's the fecal sign, mixture of air which is black and fecal content which is different shades of grey is what identifies the colon, right? Here you can compare the fecal, right, air and the grey matter, and that is not present in these loops. These are the jejunal loops, right? If fecal sign is present in the jejunal loops, it's a sign of long-standing intestinal obstruction, right? So coming back to the hepatic flexure, this is the hepatic flexure. So now again we have to go down, right? Once we get the hepatic flexure, now this is the ascending colon, right? This is the ascending colon. Now if you have noticed, there is a diverticula in this area as well. That's okay. This is the ascending colon, right? And as we go down, you will get the cecum, right? So this area is the cecum. Now this area is important because you have to see the ileocecal junction and you have to see the appendix in this area. So there are direct markers of appendicitis and there are indirect markers. If you see inflammation in this area, you should look for an inflamed appendix. In this patient, there is no inflammation and so you can see a normal appendix, right? If you can see this and it is turning like this, okay? I will remove the mark again. If you see, right, this is the cecum. So this, okay, or what I'll do is I'll put an arrow so that you can identify. Okay, just see that arrow, that is the appendix. Okay, there is air in the appendix, which means that it is normal, there is no fecolith, and as you can see it is turning here, right? It is turning, see, if you can observe this, right? So this is the appendix. This is a normal appendix because you can see air up to the tip of the appendix. Appendix may not be visualized or there will be air, and if there is contrast, there will be contrast. So that is how you can identify the appendix, right? So just to revise, you can follow it from any direction, but I like to follow it from anal canal upwards. That is how I follow it. Otherwise, you can start with the cecum, right? This is where the cecum is, and you can continue follow it. Cecum, go up, that is the ascending colon. Once the liver comes, that is the hepatic flexure. Then you have the transverse colon, right? You have the transverse colon. Then you have the area of the splenic flexure. This is the splenic flexure. So you have the pancreas, you have the spleen, and you have the kidney, right? So descending colon, as you go down, then you see the sigmoid, the characteristic looping of the sigmoid, right? The characteristic looping of the sigmoid, which opens into the rectum and then the anal canal. So that is how you can follow the colon in the axial section. We will also see it in the coronal ones. So in the coronal section also you have to do the same thing. You have to follow the intestine from anal canal or from the ascending colon, right? Anal canal, rectum, sigmoid. If you can see here, you can see a turning of the mesentery there, and then it is going up, right? So when we see, this is how it is going up, right? There is looping of the intestine. So this, if you follow, is looping at this point, right? It's turning, then it's turning on its own, and then it's going. This because sigmoid is redundant, so you may see different versions of the looping, right? But what you have to follow here is this loop, so that it connects to the descending colon, right? And then it's easy in coronal because you can see larger areas of large intestine. So this is the splenic flexure area, right? Then when you come anteriorly, you will see the entire transverse colon. That is the entire transverse colon, right? And again, as you go posteriorly, you can see the ascending colon and the cecum, right? You can see the ileocecal junction. This point is the ileocecal junction. Very important to see this point in cases of TB and typhoid. This is the ileocecal junction, right? I'll just mark it and show, right? If you can appreciate, that is the ileocecal junction, right? Also, we had seen the appendix, so you can see the appendix also. This is the appendix, right? The small air-filled structure, normal appendix, and this is the ileocecal junction, right? So that is how we follow colon, ileocecal junction, appendix in coronal as well as axial scans. Some important relations also we have seen: splenic flexure and its relation to spleen, the left kidney, pancreas, as well as the duodenum, right? If you can see, the duodenum is also quite close. When we are dissecting, that is very important point to mark, right? So these are some of the structures that we see in these cases. So now we'll see some cases of colon cancer, and that is just to highlight the importance of viewing the scans on console so that you can identify the thickening of bowel. Also, we will see the role of contrast in this imaging, and we will appreciate the need of viewing these scans very specifically with some key points in mind if we want to plan surgery or we want to completely report these scans if we are radiologists. So this is the first case, and what we are going to do is I will just scroll the console once so you can try to identify the lesion. Hint is already there that these are colon cases. So let us see if you can identify. I'm going up. Okay, and I'll go down again. Okay, I'm sure most of you would have identified a lesion in this scan. For those who have not, let us just follow our. So this is the rectum. Now as we go up, you can trace the entire sigmoid. Going up now, you can see it is going like this. Then going like this. Quite a collapsed descending colon, that is the descending colon. You can identify it by the amount of hair. This is the splenic flexure, right? This is the splenic flexure. I'll just delete the markings, and this is the splenic flexure, very collapsed splenic flexure. A very thin distal transverse colon in this area, if you can appreciate. Right? That is the transverse colon. And now if you see this area, I'll just remove my mark. This is a thickening, right? And this is where the disease is. So that is the disease in this case. It's a carcinoma of the hepatic flexure of colon on biopsy. So this is the liver, transverse colon. This is where it converts from hepatic flexure to the ascending colon, right? So if you see, this is the ascending colon and the cecum, right? So this is, you can see again, right, that area, the classical apple core appearance. This is carcinoma hepatic flexure. In these cases, what you need to see is its relation to the right kidney. Here the plane is maintained. You need to see the relation to the adrenal, and you need to see relation to the liver and gallbladder as well as the duodenum. All the relations look preserved in this case. Also, there are no perilesional nodules. There are some small nodules, if you can see, in this area, but not very significant. And this area is basically drained by the right branch of middle colic artery. So you also need to see if there are lymph nodes in that territory, right? So these are some of the findings that we look for in this case. Yes, there is subtle stranding in this area. So that is what we look for. Plus, if you notice, this is a lymph node, right? Round lymph node. So that is how you can identify lesion in colon. So this is our first case, and that is the classic apple core appearance of the hepatic flexure. So carcinoma hepatic flexure of the colon, right? Okay, we go to the next case. So again, what we will do is I will just move the console. So again, what we will do is I will just move the console, and you can try and identify the lesion as well as few other findings if you can. And then we will see it again in the way we have seen the other scans, right? So going up, again going up, right? I am sure most of you have identified. For those who have not, you would need to start seeing the scan from where it starts. There are lymph nodes in the groin. There are lymph nodes in the groin, right? Bilateral groin lymph nodes. So that you need to see. Multiple groin nodes, right? Multiple groin nodes. Yes, these were palpable nodes. They have a bearing on the management in this case. So now let us see, we will trace the rectum. This is the rectum. As I go above, converting into sigmoid, and this is the area, right? If you see, completely thickened, narrowed area, right? Sigmoid. As we go up, you can see some stranding in that area, some small serosal nodules also, right? This is a serosal nodule. If you observe, right, it is a serosal nodule. So there is serosal nodularity, and this is the loop above the lesion, right? So that is sigmoid continuing into the descending colon. Okay, now we go to the third case. Now this is a very interesting case, and I will tell you why. So let us again see this case. Now this patient has a positive contrast in the rectum as well as in the colon. So that makes it easier for you to trace the colon. So again, I will just browse the console for you, and then we will discuss the scan. So going down. So going up, splenic and the hepatic flexures can be seen in the transverse colon. Again going down, okay. So there is a catch in this scan. This patient does not have a colonic growth. Let us see. So by now you know this is the rectum, right? Anal canal, rectum, forming the sigmoid and the descending. Now nothing is there till this area, but as the descending colon came, you can see this lesion appearing and stranding also. But just follow this contrast. That is why positive contrast is very important sometimes. This is the descending colon and this is the mass. Let us see. Colon and the mass. This is the splenic flexure. So the mass is nowhere in contact with the colon, right? If you see the films only of this scan, you cannot make out these relationships. So this patient had a jejunal gist as the final histopathology once we operated. But what is very important is that this is very difficult to make out in only the film. So unless you see the console, if you see only this part, you will consider this as diverticulitis, right? But or you will consider it as a mass arising from the colon, right? But if you see these things on console, they can be very easily identified, right? Now there are other interesting findings in this case, like this lesion. Okay, now I'll remove the dot and trace it for you. Right, there is a lesion in that area. There is a big lesion in this area. So this patient had some small metastatic gist as well. Okay, if you see this one, remove the marking, metastatic gist. Right, so diagnosis came as metastatic gist. So this is the importance of viewing the scan on the consoles. So we have many cases like this, but I hope the gist of this talk is very clear, that view the scans on console, trace the entire colon and rectum, see the relationships of hepatic flexure and splenic flexure, identify the thickenings and the diverticula, look at the appendix, see the relations of these structures. When you are assessing the cancer scans, also look for metastasis and the nodes. You can see small, this is how the metastasis will look like if it is large, right? But yes, there are these small nodules. These are metastatic lesions. So look at all these points, study the scan along with the clinician who has referred the patient. And for clinicians, study the scan with your radiologist on the console to identify these points, right? Keep sharing interesting topics with us. This one was a very interesting topic, and I hope we have justified the topic on our console. Stay tuned for upcoming videos. Thank you.